Hello, our dear students. Today we're starting our second semester, and this lecture is for third year students, MA groups, the disciplines Propaedeutics of Internal Medicine. We continue lectures from previous semester in Propaedeutics of Internal Medicine. And the topic of our today's lecture is syndromes of motor function disturbances of esophagus, stomach, small and large intestine. As usual, your lecturer, it's me. My name is Maria Brinza. I'm head of Department of Propaedeutics of Internal Medicine and Physical Rehabilitation, philosophy doctor and medical doctor. And as usual, all third course, all third year, you have lecture with me. Let's start our today's work. Before we starting, let's discuss plan of our today's lecture. It is syndromes of motor dysfunction or motility disturbances. We separately going to discuss esophagus disorders, stomach disorders, intestine disorders, and all details about each of these groups. Let's start from esophagus motility disorders, and before it I'm going to give a definition. What is it? Esophagus motility disorders are any medical disorders causing difficulty in swallowing, regurgitation of food, and spasm-type pain, which can be brought by an allergic reaction to certain foods. The most prominent one is dysphagia. You heard about this symptom a lot. It is very common, and it can be specific for a big number of disorders. It may be part of CREST syndrome. It is mnemonic, refers to 5 main features. It is calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and teleangiectasia. Here you see an example, one of examples, a serious problem with esophagus that lead to motility disorders. It is a typical X-ray picture of achalasia of esophagus. You can note here a bird break appearance of the lower esophageal sphincter, which dilated barium-filled esophagus proximally to it, to this narrowing. Types of esophagus motility disorders. Dysphagia could be solid only or for solid and liquid food. A solid dysphagia is due to obstruction such as esophageal cancer, webs, or stricture. Solid plus liquid dysphagia is due to esophageal motility disorders or dysmotility, either upper esophagus, myasthenia gravis, stroke, or dermatomyositis. All lower esophagus, like for systemic sclerosis, CREST syndrome, I can repeat, it is calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and teleangiectasia. Or another type of lower esophagus motility disorder, it is achalasia. I show you it in previous picture. Here you see another esophageal motility disorder. It is the same patients with previous picture, but it is a X-ray picture after response to amyl nitrate. It is a smooth muscle relaxant. You see here a partial relaxation of lower esophageal sphincter allows some barium to pass through into the stomach. Causes. Primary causes of esophageal motility disorders are achalasia or diffuse esophageal spasm or eosinophilic esophagitis. By the systemic disorders, it can be systemic sclerosis, Chagas disease, and other systemic disorders. Here you see the esophagram of 65-year-old man with rapid onset dysphagia over 1 year. All the esophagram shows a typical picture of achalasia. This patient has adenocarcinoma of the gastroesophageal junction. This is an example of pseudoachalasia, which reinforces the absolute need for esophagogastroduodenoscopy in patients with radiologic diagnosis of achalasia. Not to make a mistake between, for example, achalasia and cancer, like in this case. You see such a significant narrowing. On X-ray, it looks like severe achalasia, but it is a case of esophageal cancer. Symptoms of esophageal motility disorders. On the picture, you see that most typical symptoms, it is feeling like something in your throat, like some foreign body. Moreover, it can be difficult to swallow in liquids or solid. We name it dysphagia, discussed it already. It can be regurgitations, heartburn, chest pain, atypical chest discomfort, vomiting, the sensation of something getting stuck, and in a chronic progression, it is weight loss. Here you see example of another patient, another case. It is an esophagram demonstrating the corkscrew esophagus picture observed in patient with manometry, confirmed finding of diffuse esophageal spasm. You see the diffuse spasm. It's not the same through the all esophagus. Yes, and it changed a form of esophagus by a diffuse local spasms. Diagnosis of esophageal motility disorders in patients with primary motility disorders result from a physical examination that often is unrevealing. Clinical signs of scleroderma in the proper clinical settings must be noted, especially skin changes. A bedside swallowing change may be performed with a glass of water. You should check general nutrition and hydration if significant dysphagia is reported. Here you see esophagram of previous patients after response to amyl nitrate. It is a smooth muscle relaxant, you remember. We see with disappearance of spasm on esophagram. It removed the spasm. The most informative and specific test for esophageal motility disorders is esophageal manometry testing that check pressure into esophagus. Otherwise, this method known as motility testing. It is used to evaluate a neuromuscular functions of esophagus. And it's performing looking like on the picture, yes, with nasal catheters that through the nose goes to the esophagus and it goes down till the stomach. And in different places of pieces of this catheter, it is placed sensors that check level of pressure. And graphically it look like on second picture. Yes, we can see in what level, what kind of pressure in esophagus, and according to it we can check is it present spasm or is it not present spasm, is motility is okay or it is abnormal. Let's start a discussion of stomach motility disorders. The definition. A gastric or stomach motility disorders are any alterations in the transit of foods and secretions into the digestive tract. By the types, it can be dilated gastric emptying or gastroparesis. It can be rapid gastric emptying or dumping syndrome. It can be functional dyspepsia. It can be idiopathic vomiting and cycling vomiting syndrome. Now we discuss each type separately a little bit. First, firstly, let's discuss general causes of all stomach motility disorders. Most often, it is neurogenic disorders, that is, diseases, metabolic diseases that lead to neuropathies, like diabetes. It is the most often cause. Moreover, it can be chronic infections. It can be other endocrine disorders, like, for example, hypothyroidism. It can be connective tissue disorders like scleroderma, autoimmune conditions, or neuromuscular systemic diseases. Often it is idiopathic. It means that we can't find any significant cause. Very often it is psychological conditions, different psychological conditions or even psychiatric conditions very connected with stomach motility, and it is researchers show us that often motility, GI motility disorders connected with different psychological and psychiatric conditions. Moreover, the causes of stomach motility problems can be eating disorders, yes, when diet is not regular or not normal, or have another person have different problems with eating. Certain cancers can lead to stomach motility disorders too. Moreover, it can be radiation treatment applied over the chest or abdomen. It can be some chemotherapy agents, surgery of the upper intestinal tract. Let's discuss a little about each form of stomach motility disorder. And first of it is gastroparesis, or delayed gastric emptying. It is poor emptying of the stomach that can occur for several reasons. First, when the outlet of the stomach, we name it pylorus, or first part incoming to duodenum, may be obstructed by an ulcer or tumor, or by something large and indigestible that was swallowed. The pyloric sphincter at the exit of the stomach may not open enough or at the right times, or allow food to pass through. The normally rhythmic 3 per minute contractions of the lower part of the stomach can become disorganized, so that the contents of the stomach are not pushed toward the pyloric sphincter. Here you see different radiologic and endoscopic finding in gastroparesis. First picture, it is simple abdomen X-rays shows dilated stomach with a food material. On picture B, we can see endoscopic severe stenosis of anastomosis site after biliary 1 gastroduodenostomy. Opening is seen in inferior direction of anastomotic site. And picture C, it is endoscopic view of gastroduodenostomy stenosis undergoing balloon dilation. It is a kind of treatment. Luminal narrowing is seen due to anastomotic stenosis. Balloon dilation by 20 to 25 to 30 psi was done for 2 minutes. They developed no complications such as bleeding due to procedure. Widening of stenotic site can be seen after the procedure. The opposite situation, it is dumping syndrome, or too fast gastric emptying. Rapid gastric emptying or dumping syndrome happens when the upper end of small intestine, that we named jejunum, fills too quickly with undigested food from the stomach. It can be early and late dumping. Early dumping syndrome begins during or right after a meal. Late dumping happens 1 to 3 hours after eating. Many people have both types have symptoms as early as late dumping syndrome. It is schematically showed the gastroparesis. Okay, next form, functional dyspepsia. It is one of the maybe even the most often form of stomach motility disorders. Many patients have pain or discomfort, like fullness, early satiety, feeling full soon after the starting to ill, bloating, nausea, that is felt in the center of abdomen above the belly button. There is no single motility disorder that explains all these symptoms, but about a third of patients with these symptoms have delayed gastric emptying. Usually not so severe that it caused frequent vomiting, and about a third show a failure of the relaxation of the upper stomach following a swallow. Abnormal gastric accommodation reflex. About half of the patients with these symptoms also have a sensitive or irritable stomach, which causes sensations of discomfort when the stomach is filled with the even small volumes of food. Please be attentive with this form. You will learn more on your practical classes because this disorder is very often. Pathophysiologically, it have different factors. It is multifactorial, and the complex of them usually leads to functional dyspepsia. Because as for other functional disorders, we don't have any exact one cause of this disease. It is a complex of different factors, like risk factors and small causes and predisposing factors. What are them for functional dyspepsia? On the scheme we see it is visceral hypersensitivity, it is disrupted gut immune interactions, it is abnormal upper GI motor reflex functions, it is psychological factors. I told you that it is very connected with GI. It is genetic factors, but it's not not showed a direct connection between some gene and functional dyspepsia, but a big number of researchers, big number of papers show us that some connection between them is present. And it is altered brain-gut interactions. Next form of stomach motility disorders, it is cycling vomiting with recurrent episode of severe nausea and vomiting interspersed with the symptoms-free periods. Cyclic vomiting syndrome occurs in all ages. Patients may struggle for many years before a correct diagnosis is made. Symptoms: it is nausea or vomiting. It is retching by like dry heaves. It is bloating, upper abdominal pain, stomach fullness after a normal sized meal. It is early fullness or satiety with an inability to finish a meal. It is weight loss due to a decreased appetite. Okay, gastric motility procedures. What can we do to confirm diagnosis with stomach motility disorders? It is smart pill wireless motility capsule. For today, it is the most modern and most effective way to put a diagnosis. It is a pill-sized sensor that is swallowed and measures temperature, pH, pressure, how quickly the stomach empties, how quickly the small intestine and colon empty. H. pylori testing can be done with a blood antibody test, breath test, stool antigen test, or stomach biopsy. All these ways are effective to confirm presence of infection Helicobacter pylori and confirm connecting it with the stomach motility disorder, for example, functional dyspepsia. Breath testing that can help detect a food intolerance, bacterial overgrowth, irritable bowel syndrome, fructose intolerance, lactose intolerance, and constipations. Yeah, it is a photo of device for smart pill wireless motility capsule. Yes, it really a small capsule like a pill with a camera and sensors, and a patient peruse drink it with the food or water. After it, this capsule registers all the parameters that we discussed earlier and sends it to computer and on the monitors. H. pylori testing, I told that it is a different way: breath test, blood test, urine test, stool test, all of them are okay. The simplest one, it is testing by H. pylori strip. We make sample and use it with a buffer and test strip, and like for other express tests, for example different other infections, yes, it have two regimes: positive and negative result. Breathing test, you know that it is it sends concentration of urea in breathing air. And according to this concentration, we can confirm presence or not confirm presence of H. pylori infection. And let's start intestine problems. Intestine motility disorders. Let's give a definition. Phrase intestinal motility disorders applies to abnormal intestinal construction such as spasm and intestinal paralysis. This phrase is used to describe a variety of disorders in which the gut has lost its ability to coordinate muscular activity because of endogenous or exogenous causes. Mechanisms. Here you see that main mechanisms lie in connection between central nervous system and innervation of GI tract, specifically innervation of intestine. And this interconnection between central nervous system and GI tract, abnormal response of central nervous system with hypermotility or hypomotility on the sensor factors lead to different motility disorders. Causes. Causes seem to be multifactorial too, as for stomach, and only a few have been detected. First, it is degenerative disorders cause pseudo-obstruction along the other problems. Next one, it is the drugs that are commonly used. Confirmed drugs that connected with intestine motility disorders are tricyclic antidepressants, some kind of diuretics, laxative, or have some specific indications like drugs like lithium salts, vinca alkaloids, and other chemotherapy agents. They may interfere with intestinal motility. Different endocrine disorders like myxedema, diabetes here too, and they also can cause pseudo-obstruction. And some connection with genetic factors was shown in researches too. Manifestations. Manifestations of intestinal motility disorders can be different. Often it is abdominal distension, recurrent obstruction, severe abdominal colicky pain, constipations, gastroesophageal reflux disease, and intractable recurrent vomiting. And on the picture, I stop on one of the most often and maybe one of the most important and often problems that meet a million people over the world. It is constipations. Yes, one of the and maybe the most often form of intestinal motility disorder. And let's discuss 15 main causes of constipations. Yes, it is poor diet. It is diet with lack of fibers. It is lack of exercise, medications, underactive thyroid, irritable bowel syndrome or IBS, perianal pain, neurological conditions, not enough water in diet, or hypohydration, poor toilet habits, it is stresses, overuse the laxative drugs, bowel cancer, potty training, traveling a lot, and pregnancy. It is different and common causes of constipations. Clinical signs. Presentations of intestinal motility disorders can be with intestinal pseudo-obstruction, like Ogilvy syndrome, with irritable bowel syndrome or IBS, with fecal incontinence and constipation. One of the methods to confirm, if we know, now we don't discuss classical methods like radiological investigations, CT, MRI, and X-ray and ultrasound, but some specific kind of investigation of intestinal motility, it is endoscopic ultrasound. And for example, on this picture we see anterior defect in internal and external anal sphincter. And we have specific classification for intestinal motility disorders. It is Nose-Martin classification. It includes delayed colonic transit. It is slow transit constipation, like enteric neuropathy, enteric myopathy, Parkinson's disease, endocrine disorders, and spinal injury. Next form, it is dilated colon, like diffuse or segmental. We name it Ogilvy syndrome and megacolon. Next form, it is absent rectal anal inhibitory reflex. We name it Hirschsprung disease. One more method for you, it's rare method too. Now I don't stop on typical methods. One of the unusual method, it is GI scintigraphy. It is a quite effective method that can help you visualize GI tract in general and its motility specifically. For example, here in these 2-hour images, we can note the normal empty, like 31% empty, with normal range from 31 to 67%. In the left image, with significantly more tracer shown in small intestine than in the right image, which shows a delayed empty. Here is just 26% empty and much less tracer in the intestine. Symptoms of intestinal motility disorders. Clinically, it usually have presentations with pain, bloating, disturbed bowel motion, feeling full after having eaten only a small amount, nausea, vomiting, severe constipation. And here you can pay attention to the picture that you see here. Maybe someone know why I include it in this slide in the part with intestine motility disorder. If you know how it connected, you see that it is female jogging 30 minutes 3 times a week. If somebody know how it connected with intestine motility disorders, you can write in the comments. Okay, another testing, you see here an examples. For example, first picture, it is endoscopic, a picture of placement of guide wire for motility catheter. And second one, it is a placement of colonic motility catheter, but it is X-ray picture. On physical examination, a clinical picture of patient with intestinal motility disorders during examination. It is protein and may vary greatly. It is depending on specific condition present. You should always perform a digital rectal examination at any patient with an intestinal motility disorder to detect presence of mass. It can be feces, tumor, or foreign body. And presence blood in the rectum. One more method, it is defectography. It is radiological method too, but it connected with placing a contrast. With contrast, you see an examples of intestinal problem. On the first picture, it is anterior rectus cell. And second picture, it is anterior rectus cell that does not empty even during the motions of intestine. Okay, and syndromes that I want more to discuss today with you. And clinically, if motion problems is pathophysiologically and theoretically is more very important and understandable, clinically we have even more important two other syndromes. These syndromes names syndromes of maldigestion and malabsorption. Let's give definition to them. Maldigestion describes the inability of an individual to digest food entered in the gut. Malabsorption, it is an inability to absorb nutrients which have been digested from food through the gut. What organs are connected, what target organs can suffer from syndromes of maldigestion and malabsorption? You see that it's nearly all organs and systems. It includes sperm, eggs, kidney, liver, bone, lung, brain, blood, heart, muscle problems, pancreas problems, and all other organs can suffer from syndromes of maldigestion and malabsorption because of abnormal income of macro and micronutrients to the organism, which are main for energy producing, for metabolism, and all processes in our organism. That's why these two syndromes are very, very important for understanding. Causes. The most often of them, it is congenital heart disease. It can be cystic fibrosis. It can be gastroenteritis, HIV infections, liver disease, short bowel syndrome, toddler's diarrhea, etc. In general, it is a huge number of different disorders that can lead to maldigestion and malabsorption. And on this slide, it's just main of them. And you see that they are very multisystemic. It can be respiratory, cardiac, GI, metabolic, different infections. Huge number of different disorders can lead to these two syndromes. Clinical symptoms. include GI manifestation and not GI manifestation. GI manifestation include diarrhea, steatorrhea, weight loss, flatulence, pain, abdominal bloating, abdominal cramps, abdominal discomfort, swelling or edema, and muscle cramps. It can include biopsy, it confirmed by biopsy, and here you see examples of histological examination. Here are difficult kinds of changing of mucus of intestine. It is inflammation, hypertrophy, atrophy, edema. And all of these problems with intestinal mucus can lead to abnormal absorption and abnormal digestion and lead to these two our syndromes. Extraintestinal manifestation of maldigestion and malabsorption syndromes. Patients with celiac disease present with anemia and osteopenia in the absence of classic GI symptoms. Microcytic and macrocytic or dimorphic anemia may reflect impaired iron, folate, or vitamin B12 absorption. All these forms of anemias can be in patients with maldigestion and malabsorption. Purpura, subconjunctival hemorrhage may reflect hyperprothrombinemia secondary to vitamin K malabsorption. Osteopenia is common, especially in the presence of steatorrhea, impaired calcium and vitamin D absorption, and chelation of calcium by unabsorbed fatty acids resulting in fecal loss of calcium may all contribute. Dermatitis and peripheral neuropathy may be caused by malabsorption of specific vitamins or macronutrients and essential fatty acids. And here you see a quite difficult scheme of pathophysiology of B12 deficiency. Due to maldigestion and malabsorption. Complications of syndromes of maldigestion and malabsorption. Both of them, maldigestion and malabsorption, can lead to deficiencies, for example, in vitamins and minerals as well as protein and energy. The complications that can develop depend upon which nutrients are affected. For example, calcium and vitamin D deficit can lead to rickets and osteopenia. Sorry, 1 second. For example, calcium and vitamin D deficit can lead to rickets and osteopenia. Iron deficiency is associated with anemia. Zinc deficiency has been linked to poor growth. Problems with absorbing protein, fats, and carbohydrates can culminate in a weight loss and undernutrition with wasting and, in severe cases, stunting. Here you see connection between malabsorption and vitamin D. In an adult person, it can lead to different changes, metabolic changes, to osteoporosis, the bone problems, and deficiency of vitamin D in children can lead to problems with growth and bone formation. Diagnosis of syndromes of maldigestion and malabsorption. There is no single specific test. A range of different conditions can produce maldigestion and malabsorption, and it is necessary to look for each of these specifically. Many tests have been advocated, and some, such as tests for pancreatic functions, are complex, vary between centers, and have not been widely adopted. Tests are also needed to detect the systemic effects of deficiency of the malabsorbed nutrients, such as anemia and vitamin B12 malabsorption. Here you see a simple scheme of malabsorption, problem with absorption through the mucus through the microvilli in intestine epithelium. Blood testing in patients with maldigestion and malabsorption. It is very important for these two syndromes. The routine blood tests may reveal anemia, high CRP, C-reactive protein, or low albumin. Microcytic anemia usually implies iron deficiency, and microcytosis can be caused by impaired folic acid or B12 absorption or both. Low cholesterol or triglyceride may give a clue towards fat malabsorption. Low calcium and phosphate may give a clue towards osteomalacia from low vitamin D. Specific vitamins like vitamin D or micronutrient like zinc levels can be checked. Fat-soluble vitamins like A, D, E, and K are affected in fat malabsorption. Prolonged prothrombin time can be caused by vitamin K deficiency. Immunoglobulin A anti-transglutaminase antibodies or immunoglobulin A anti-endomyosal antibodies for celiac disease can be detected. Celiac disease, another name, the gluten-sensitive enteropathy. And scheme of fat malabsorption. Yes, it is the most often kind of malabsorption. The main causes of it is lymphatic obstruction, like for example in allergic eosinophilic gastroenteritis. It is reduced small intestinal surface, like for example in tuberculosis or tuberculous lymphadenitis. Or it can be iatrogenic, for example due to surgical short gut syndrome. Stool studies. Microscopy is particularly useful in diarrhea. It may show protozoa like Giardia, ova, cyst, other infective agents. A fecal fat study to diagnose steatorrhea is rarely performed nowadays. Low fecal pancreatic elastase is indicative of pancreatic insufficiency. Chymotrypsin and pancreolauryl can be accessed as well. And here you see mechanisms of diarrhea and malabsorption, and you see the character of and parameters of diarrhea by mucosal resistance, by spontaneous PD, pressure, and absorptive mechanisms according in what part of intestine is problem. Is it ileum, cecum, proximal or distal colon? It is different characteristics and clinical symptoms of diarrhea. And for your own control, I add one question. Who are interested in it, who was attentive during lecture, please answer your variant in the comments under the video. The question from USMLE. A 22-year-old female presents to your office with gas, abdominal distension, and explosive diarrhea. She normally enjoys eating cheese but has been experiencing these symptoms after eating it for the past few months. She has otherwise been entirely well, except for a few days of nausea, diarrhea, and vomiting early in the year, from which she recovered without treatment. Which of the following laboratory findings would you expect to find during workup of this patient? First option, it is decreased stool osmolar gap. Second, decreased stool pH. Third, positive fecal smear for leukocytes. Fourth, positive stool culture for rotavirus. And positive stool culture for Treponema whippley. Not a difficult question for them who listening the lecture. For today, that's all material. If you have additional comments, questions, or maybe some information additionally you need, you can write it in the comments under the video on YouTube, or in our department Facebook page, where we are always ready for your feedback, for your questions, for some interesting discussions. And as usual, I ask all students who listen in lecture, write your name and group under the video in comments to controlling their attendance. For today, that's all. See you on the next lecture in 2 weeks, and have a good day. Goodbye.